Hello, my name is Kevin Crocker. I am the Division Chief of Quality and Process Improvement here at MCHD. This video is going to cover the MCHD triage system. So as part of this video, we're going to cover mass casualty incidents, what that means, and triage, and then review MCHD's approach to triage and MCIs. So what is the definition of a mass casualty incident or an MCI? The textbook definition of an MCI is anytime the number of patients outnumbers the number of resources you have available. So if you close your eyes now and you picture the word MCI, you probably see something similar to what you see on the screen here. The big tarps with the green, the yellow, and the red, lots of responders, lots of patients, and that is the definition of an MCI, and this absolutely qualifies for an MCI. You also see things like this. So this is the Boston bombing here on the left. Big explosion, lots of people around, so lots of potential injuries. Being the first responder there, having to sort that out, that's kind of what you think of as MCI. The big charter bus there on the freeway with 50 kids in it who are coming back from their high school football game and having to sort through those injuries. Those are classic MCIs that you're accustomed to and what you think of when you hear and think of the word MCI. But there's also other types of MCIs that we do encounter on a routine basis, and I would argue that EMS professionals, providers, firefighters encounter these types of MCIs on a daily basis. So on the left-hand side of the screen, you see a 4-vehicle accident. So assume there's 2 people in each one of those vehicles, that's 8 patients. If you're the first responder, first responding unit on scene of that 4-vehicle accident with 8 patients in it, that is technically by definition an MCI. And I think we do that every single day here at MCHD, multiple times a day. That is an MCI because there's more patients than there are resources. Those are lower scale MCIs that you're very accustomed to dealing with on a routine basis, and you're good at it. And the EMS profession, paramedics, EMTs, firefighters, you're trained at how to deal with these types of situations. The picture on the right could also be considered an MCI. So you go to a group home and there's a viral illness in the group home and you end up having 3 or 4 patients, or you have a mom and a dad and a kid, or a mom and dad and a grandma who are sick with a viral illness. We also handle those calls on a routine basis. Again, the number of patients exceeds the number of resources that you have available in that moment. That is by textbook definition an MCI, not a classic MCI. It's not what you see when you close your eyes, but the same principles apply. You have to identify which patient's the sickest and what needs what first, and you have to sort through those. So that is also an MCI. I would also argue that this here is an MCI, and I know this is an ICU picture, but we encounter ICU level patients on a routine basis, and while the number of patients doesn't outnumber the number of resources you have, the number of procedures you have to do and the number of interventions you have to perform for that patient outnumbers the hands you have available, and you have to triage what you're going to do first. And you can picture these patients. You can picture the trauma activation patient who has massive external hemorrhage that needs bleeding control, and they also are seizing, and they also have airway management concerns, and they also have blood pressure issues. How do you triage which one of these skills or interventions needs to be done first to save that patient's life? And these are things that we do on a routine basis. And I say all that just to reframe our thought process of what an MCI is and get you in the mindset of these are things that you're very comfortable and accustomed to doing on a routine basis in a daily 911 system. So triage. We've talked about the word triage a couple of times now. What is triage? Triage is something that's pretty natural to, I would say, humans in general, but triage is something that's ingrained in EMS professionals and firefighters in the work we do every single day you come to work. And the purpose of triage is to prioritize the sickest patients and then prioritize what to do first. So sickest patients, identify the ones that have the highest life-threatening injuries, treat those injuries as much as possible, and get them routed to the appropriate destination the quickest. But when you go back to that ICU patient, like, what do you do first? So do you control the external hemorrhage? Do you bag them? Do you put OPAs in? Do you put an IV and get fluid started? So prioritizing your task list of things you need to do to save that patient's life. And those are things that we do on a routine basis. All right, so from a triage standpoint, there is a national, actually it's more global than national, but we're in the US, so we'll talk about US today. There's a pretty standardized color system when you think about MCIs. And you're all familiar with that, and you can close your eyes and see the colors in your brain today. On the right-hand side of the screen, you see what is a kind of a classic triage tag. There are different variations, but this is kind of the more common one. You see they're pretty complex. There's lots of tick boxes, lots of blanks, lots of vital signs. But those are what you normally think of when you're triaging and tagging patients as the triage tag. The important part of the triage tag is on the bottom corner there. You see different colors. You see the black, the red, the yellow, and the green. And these are kind of complex too. We do a lot of MCI drills here at MCHD, and we find lots of errors with that because you're not really sure which part to leave with the patient, where to tear, what to leave, how to re-triage, all those things. Those are some of the complexities. But the important part of what I wanted to go over this slide is the national color set. This is standardized, and it's a universal language across the healthcare continuum here in the US. So whether you're talking to law enforcement, fire, EMS, hospital partners, trauma surgeons, everybody's familiar with this language. And that's why it's important that we use this language and we're familiar with it. So black is deceased or dead, red is immediate, yellow is delayed, and green is minor. So if you have an MCI that has a lot of patients, and you call the hospital and say, I have 2 red patients, 6 yellows, and 12 greens. Without giving a whole lot more description other than that, they kind of can close their eyes and see what kind of acuity they can expect to receive and how to plan their resources. That's why using that universal language is important, and we do follow that universal language here at MCHD. As far as how to get to those, there are a couple triage algorithms that exist that are pretty nationally used. So you have Start Triage and RPM Triage are probably the 2 most common. There are other global ones that are more complex. There are ones that are more simple, but these are kind of the ones you'll hear about most here in the United States and here in Texas. You'll see that they're algorithm based, which is how human brains work. They kind of follow an algorithmic process. They're based a lot on vital signs, mentation, and they kind of, the ultimate goal of both of these is to help providers and paramedics and firefighters and nurses when they're encountering a large volume of patients to quickly separate patients into a category to make sure we're getting them the right resources at the right time. There's nothing wrong with these triage systems. They work well. They're a little complex and hard to remember when it's not something you practice and do on a daily basis. And for the most part, people are not pulling out START and RPM cards to use on that 2 and 3 vehicle accident we reviewed earlier. So we'll get to the meat of this presentation. We're going to talk about the MCHD triage system. We developed the MCHD triage system based off kind of what I just talked about. RPM and START work well, but they're complex and they're not things that you use every day. And they're not really natural, even though they're algorithm, because you have to remember each step of the algorithm to triage them to the right spot. The genesis of the MCHD triage system was not to not use START triage or RPM. It's really more to mimic what happens in real life every single day on the streets, in the fire apparatus, and in the ambulances on our roads. For the most part, people are triaging based off what they see and not following the algorithm. And we really wanted to create an algorithm system that would reflect really how things practice on a daily basis and was easy to remember. The MCHD triage system is really based on a couple of simple principles. First off, it's in your head. As you think back to the scenarios I showed you earlier, the big MCIs, we don't run many of those. Not many people have encountered those. So it's really hard to reflect on what you would do in those situations or what you did in those situations. But it is easy to reflect on the last 3 or 4 motor vehicle accident you ran and how you separated and triaged those patients. Or the time you were in the group home and you had 3 or 4 patients, how you got the resources and prioritized tasks in those situations. And my gut says that most of the time you didn't use RPM or START, you used what was in your head. Dr. Robert Dixon was our medical director here for a long time, recently retired. He used to say, is the patient sick or not sick? And that's what EMS professionals, paramedics, EMTs are really good at, is looking at patients and saying sick or not sick. So you use your gestalt or your gut. When you see a patient, within 10 to 15 seconds, after visually seeing them and doing a quick assessment, you're able to identify if patients are sick or not sick. And that's really the key of how the MCHD triage system works. It's easy, it's quick, and most importantly, it's principles that you use every single day on every single call, on every single patient that you encounter in our system. It's really built around that first gut impression or the primary survey when you encounter a patient. When you see these bullet points here, you'll see that there's a lot of crossover between these bullet points and the national triage systems of RPM and START. So is the patient awake? So do they have a normal mental status? Are they confused? Are they unconscious? Is their breathing normal? You can look and see, is it rapid? Is it shallow? The radial pulse quality, is it absent? Is it fast? Is it rapid? Is it normal? And quick assessment for external hemorrhage that may require a tourniquet or pressure to stop the bleeding immediately. How long does that take? I would say it's about 10 seconds for the most part, for most providers, to quickly look at a patient, look at their mental status, look at their breathing, check their circulation, and look for hemorrhage. That's really the simple part of MCHD triage, is when you walk in and see a patient like you do every single day, those same principles apply in these mass casualty situations as well. So you'll use your primary survey to identify sick versus not sick. So the MCHD triage was built using MCHD as the abbreviation because we were looking for something simple that's easy to remember. And here in Montgomery County, when you come to work, when you check off your truck, there's an MCHD on the side of the truck. It's on your badge. It's on your uniform. So it was something that we thought may be able to stick easier in the forefront of people's brains, that they can retrieve quicker when they do run into an MCI situation where they need to use triage. So we use MCHD, and then you'll see that we use the national color system, the green, yellow, red, and black, to correspond with that. So M for MCHD is mobile, which is green. C is concerned, which is yellow. H, red, high life threats. And D is for deceased, which is black. Now we'll kind of dig into each one of these. So M, mobile, is really your minor patients, your green patients. Any MCI class or triage class you've ever taken, one of the first things they say when you walk up to a scene of MCI is you should say, if you can hear my voice, walk to me, or walk to this certain location. And patients who are able to hear you, stand up, and walk to you are generally classified as green. That doesn't mean they're necessarily stay green, and we'll talk about retriage a little later in the presentation. But initially, patients who can answer you, so they do not have altered mental status because they heard you, they understood the command you gave, they followed that command, they were able to stand up and walk, so there's probably no massive external hemorrhage that prevents them from walking. Their respirations and their pulse quality are probably decent because they're perfusing and oxygenating okay. That doesn't mean it doesn't change again, but initial quick triage, patients who can follow those commands and move to a certain location and don't have any obvious visible injuries get classified as M or green. C, concerned. So these are the patients who, once you've made that command of, if you can hear my voice, stand up and walk to me, they weren't able to do that. So these require a little more investigation. So once you start your triage process and you are evaluating the patients who were not classified as green initially, patients who hit the yellow or the concern categories, they may have injuries that are not life-threatening. So they may have a lower limb fracture or a foot fracture or a twisted ankle or an arm fracture. But their airway is open, it's patent, they're breathing normal, they have normal radial pulses, so you don't have any oxygenation concerns, you don't really have any circulation concerns because their skin looks normal and their pulse rate is normal, and they're breathing okay. But they may have some injuries that are concerning, so they do need some treatment, but it can be delayed because they don't have any high life threats or immediate life concerns that you're identifying on that quick primary assessment. So they get categorized into the yellow or the concern category. So red stands for high life threats. When we say high life threats, I think you can all close your eyes and picture an MCI and identify a high life threat patient. Those are really kind of categorized as your level 1 trauma activation patients. So they have altered mental status, or they're unconscious. They have airway concerns. So they're breathing, but it's gurgling, or it's really, really rapid or really shallow. they don't have radial pulses, or they have very tachycardic, thready radial pulses, or very slow radial pulses, so some abnormality in the circulation system, or they have life-threatening injuries. So they have penetrating injuries to the chest or the upper extremities, or they have amputations, things like that, that when you run 911 calls on a routine basis and you see these external injuries that you know need immediate care at a level 1 trauma center, level 2 trauma center, those are the ones we kind of think of when we think of the high life threat red patients. And then black or deceased is the last category. So injuries that are incompatible with life, they have no breathing, they have no pulse. Those can be pretty easy to identify. In MCI situations and triage situations, these patients are different than our routine every single day. If we encounter a patient who's had a traumatic event and not breathing and doesn't have a pulse, and they're the only patient there, there's times where we may choose to work that patient in a routine system. But in a mass casualty situation where there's 30 other patients that need care, the patients who are not breathing or do not have pulse are classified as black or deceased. And really the point of that is to make sure we're triaging and prioritizing our resources to take care of those red, high life threat patients to make sure they don't progress to the black category. I mentioned reevaluation or retriage earlier. The triage process never really stops in these MCI situations, especially the bigger they get and the more patients you have, because it's going to take more time to move those patients off the scene to their definitive care. So having somebody or a location, whether that's one triage officer who's bouncing around and reassessing patients, or you have a designated triage officer in each green, yellow, red area to check on patients to make sure that things haven't changed from the first time they were triaged is very important. For the most part, if somebody's a red, they're probably not going to triage back to a yellow because you've already identified a high life threat. But there are definitely situations where patients who were initially green may begin having ultramental status, or their breathing may change depending on what their underlying physiology is. So having somebody available to re-triage, reevaluate, and then reprioritize the care for those patients and the transport for those patients is vitally important in any MCI situation. We talked about triage tags earlier. Here at MCHD, we will not be using triage tags for a lot of reasons, but they're very complex. We find lots of errors when people use them. They're overly complex as far as the data they want written onto the triage tags. It's really just more information than needs to be in these time-critical, time-sensitive situations. So we're going to use a ribbon or a tape system, depending on what's available when we're rolling this out or restocking. So, but there'll be simple waist, I don't want to say fanny packs, but probably fanny pack kind of situation where you'll have black, yellow, red, green, ribbon or tape. Tape's where we're going to start. So you'll have rolls of duct tape. When you encounter these patients and you triage them and you've categorized them as green or yellow or red, it's important that you do mark them so that we know they've been triaged. So you'll put a piece of green, yellow, red, or black tape on the patient. Make sure it's in a location that's easily visible to other responders who are following up or re-triaging to make sure that they can see that the patient's already been triaged, already been accounted for, and if they need to be re-triaged, we can easily remove the tape and put on the next piece of tape for whatever color is most appropriate for that patient. So we'll go through a couple scenarios now. I know it's a lot of information, so let's try to practically apply that. So scenario one, you have an explosion at a concert. There were 42 total patients at the venue. The first patient is a female. She's alert, oriented. She walks towards the responders. She tells you her name's Candy with an I, and there's a little heart over the eye. So she complains of some arm pain. She has no decreased sensation or movement in that extremity. She has good capillary fill and her radial pulses are normal. So what do you categorize that patient as? She's an M or a green, so mobile green. For the reasons that she's alert and oriented. You ask, hey, if you can hear my voice, please walk to me. She stood up and walked to you. You visually assessed her. You didn't identify any life threats. Her breathing looked normal. Her radial pulse was normal. So she's a green patient. Next, you're at a 5-vehicle motor vehicle accident with a bus rollover. You encounter this gentleman right here. You're the first and only unit on scene. This is the first patient you get to. He's unresponsive. He's slumped over the steering wheel, has obvious injury to his head and he's not breathing. What is that patient? He's deceased, so he's a black patient, because we need to continue our triage process to identify the high life threats to ensure we're getting the right resources to the right patient. Next scenario, this is an active shooter situation. So there's 8 total patients involved. This patient you encountered, he's pale, he's diaphoretic, but alert. He's screaming in pain. He has a gunshot wound to the left upper thigh. There's pulsatile bleeding prior to a tourniquet, which was placed by law enforcement prior to your arrival. So you identified this patient has which color? Red, or a high life threat. He's a high life threat because he's pale and diaphoretic. So there's clearly some circulation issues going on with this patient. He has massive external hemorrhage that's having to be managed with a tourniquet placement. So he has injuries that are high life in his gunshot wound, and he also has some physiological changes with his pale diaphoretic that is time sensitive, and he needs to be treated very quickly at a trauma center, and that's why he's red or high life threat. Next scenario, this is an auto accident versus 12 bicyclists. 4 of them got away and were unscathed and totally fine. We have 8 total patients. The patient does know his name, but he's confused about his location. He's not sure how he got here or what happened. He's holding his left arm. There's some numbness in that arm and can move his fingers. What do you categorize that patient as? I would categorize this one as yellow due to the ultramental status. So he is confused. He does know his name, but he doesn't know the location or he doesn't know what happened. There's no other real injuries here that are overly concerning. He does have some numbness in his arm that may be a problem, but as of right now, the airway's intact. He's breathing normal. His radial pulse is present. The skin looks normal. So he falls into that yellow concern category because he definitely needs treatment, but it can be delayed. This is a patient that's important to make sure you re-triage later to make sure the confusion doesn't continue to deteriorate into being unresponsive. All right, let's circle back to that first 5-vehicle motor vehicle accident you encountered with the bus rollover. Had 22 patients. You now have plenty of resources. There's a provider for every single patient there, and you're rechecking. So we're doing that re-triage, and we find this gentleman still slumped over the wheel, still has the blood coming from his head injury, but he has gasping respirations and a weak peripheral pulse. What do we categorize that patient as now? He's red. So just because he was black initially on re-triage doesn't mean he has to stay black. He now has some air movement, some respiratory drive, and has some peripheral pulses. That's a red patient. He has high life threats. He's unconscious. While he does have respirations, they're not good quality respirations. So that would fall into that red category. Bicycle team crash. So you're working the Tour de France. There's 10 bikes that crash. You've encountered this patient here. There's 10 total patients. He's alert. He's oriented. He answers all your questions. He tells you his name's Thatchery. He wears a helmet when he fell. He has some superficial road rash in a couple different areas on his body. So a little bit of tenderness to his elbow, but he can move his arm just fine. He has leg pain, which makes him unable to walk, but he doesn't have any deformity, no loss of movement, no loss of sensations. So what would you categorize this patient as? I would categorize this one as green. This was interesting because initially when you said, if you hear my voice, can you stand up and walk? He didn't stand up and walk because of his leg pain. But when you actually get in and triage him, you don't identify anything that's really concerning outside of the road rash. So he has minor injuries. He's alert, he's oriented, his respiratory rate is normal, his pulse rate's normal, has good quality radial pulses, and the injuries you see are really superficial. So you can categorize this patient as green. When I started in EMS 22, 23 years ago, I was taught the KISS principle. And I think that's really what the MCHD triage system is about. It's keep it super simple. Triage does not have to be a very complex algorithm where you have to count specific respirations and count specific pulse rate. I think there's an easier way to do it. And really the easier way to do it is to apply the skills and knowledge that you guys use every single day on every single call. In the words of Dr. Dixon, sick or not sick. So using that primary survey, identifying those patients who have the high life threats that need immediate attention or need immediate transport, and using your gestalt and your gut to identify those patients. Thank you guys very much for your time, and I appreciate it. Hopefully this video was helpful.